Welcome everyone to today's webinar entitled Health Literacy Strategies, Communicating the Complexities of Transplantation. We're excited that you all could join us, and we have what I'm sure will be a fantastic presentation planned for you today. My name is Corey Bryant, and I'm the Communications Manager for the Alliance, and I have the pleasure of being your host this afternoon. We have a few housekeeping items to go over before we begin today's program. For those of you who have never joined us before on this webinar platform, the chat feature is located in the bottom left-hand corner. If you have any questions that come up during the webinar, feel free to submit them at any time, and once the presentation is complete, we'll have some time for our presenter to address as many of your questions as time allows. We are recording this webinar, so we'll not be opening the phone lines, and that means that all questions must be submitted using the chat feature. Registration is currently open for our upcoming Get Connected webinar on February 6th. It's entitled Transplantation of HCV-positive organs into HCV-negative recipients. So we hope you'll make plans to join us on February 6th at 2 p.m. Eastern Time for that webinar. Now, for today's webinar, we are offering 1 STEP-C credit and 1 nursing contact hour, courtesy of Iowa Donor Network. Everyone who is listening to today's webinar is entitled to claim continuing education credits. So if you're listening in a group, and we know that many of you are, please make sure to get the evaluation email from your group lead. It's a very brief online evaluation which will allow you to receive your credit. Also, one note for nursing, you'll have 14 days to claim your CEs, and for SEP-Cs, you'll have 30 calendar days. So at this point, I'd like to introduce our moderator, Ms. Linda Oler. She is the Associate Director of Quality, Regulatory, and Education for NYU Langone Medical Center. Linda has worked in transplantation since 1988. She served on the Board of Directors for the International Society of Heart and Lung Transplantation, and she served on 4 UNOS committees. She's also been on AST and ASTF committees, as well as those for NATCO and ITNS. She's published 4 books on transplantation for nurses and served as the editor of Progress in Transplantation for 23 years. Linda, it's an honor to have you with us, and at this point, I'll turn it over to you to introduce our speaker.
Thank you, Corey. It's my pleasure to introduce Dr. Catina O'Leary, who is President and CEO of Health Literacy Media, HLM, a nonprofit health communications committee located in downtown St. Louis. Under her direction, HLM's service network has expanded to include pharmaceutical companies, hospital systems, business coalitions, and community-based organizations. Before her appointment as CEO of HLM, Dr. O'Leary was a faculty member at Wash University School of Medicine, where she oversaw large-scale, international-based, community-engaged research project. Dr. O'Leary participates actively in her communities as a board or other advisory member for many nonprofits focused on health-related issues. She serves as a member of the National Academy of Sciences Roundtable on Health Literacy. It is our privilege to have her speaking to us today on health literacy and the complexities of transplantation. Thank you. Dr. O'Leary?
Thank you so much, Linda, Corey. I appreciate the opportunity to speak to the group. I'm going to speak today about health literacy strategies and communicating the complexities of transplantation. And I just want to start this conversation by saying health literacy is my expertise, and it's a really narrow lane, and I really hope to help you think about how to apply it to your lane, which is much broader. You all know the story of transplantation and the communities you work in, and I hope to give you some strategies to apply there to help you do your work in a way that feels better and serves your patients. So the other piece of information that I want to share just as we start is our information on transplant really comes from our wonderful partners at the Transplant Research and Education Center with Dr. Amy Waterman and her staff there at UCLA. So the work that we present on transplant-specific slides really come from Amy and that group, and we think about the application of health literacy. We're really appreciative of that work, and we hope that it can be helpful. At Health Literacy Media, we do lots of work that you think about in traditional health communications company. We have partners in training areas where we focus on digital and social media services, video creation. We think about materials and revisions, and then in training, we train people in audiences like this one to think about the work and how it applies to their activities. So I'll show you some of those examples as we go along, but this kind of training that we're doing today is one example of our work. And as we get started, we'll think about then activities that, when we think about health literacy and why that's important, we want to share that with you. We're also going to talk about what health literacy strategies can you use with patients. How can you know if patients are ready to learn about transplant? What strategies you use at each stage of readiness, and we're going to share with you some resources for your patients. So thinking about health literacy. At Health Literacy Media, we think about health literacy as an intersection of communication factors that affect health. To be successful, it has to be clear, the communication between professionals, the patients, and the systems they use. So as you would expect, research shows that patients have better health outcomes when they understand their instructions, they know how to take their medicines correctly, and they know who to call when they have questions. There's a 2013 report by the World Health Organization focused on health literacy that discusses health literacy as a stronger predictor of an individual's health status than income, employment status, education level, and racial or ethnic groups. So when you think about all those factors that impact how people learn and process information, health literacy really is one of the social determinants that matters the most. It's an intersection of factors that affect health, and the key contributors really are the system-level factors. So this is related to the complexity of the U.S. healthcare system and health insurance system, and the demands that it places on a person, like the policies and procedures, the environment and the physical space, information that constantly changes, and then, of course, the navigation of those systems, how people get around. Patient factors affect health literacy, and these are the things that are related to the person, like their ability to read, write, and communicate information, their confidence, their emotions and attitudes about their health and the health information that they need to process, and then, of course, their knowledge of what's going on in the system and what they need to do. Healthcare professionals are also a part of this system, and there are factors related to healthcare professionals that include how they communicate information in writing and when speaking, the words they use, as well as their nonverbal behaviors impact health literacy. So one of the most important points about all of these factors, though, is that they're dynamic, meaning that the role each plays in health communication changes depending on the situation. So, for example, sometimes some of us go to a health situation where we're the people that are in charge, we're the providers, we provide information over and over again, and we're very health literate, and we're very comfortable, and we have lots of certainty. The same people who are providers in one setting maybe go for their own health care or that of a person that they love very dearly, and they get a new diagnosis for cancer or heart condition or some other major condition, and suddenly all of that confidence and assurance that they had when dealing with patients changes because they're suddenly the patient and it's a novel health situation. So that dynamic nature of health communication is really important. So there are some examples of health literacy in action that we'll talk about today. It plays a role in everyday life, health literacy does, and some of the examples are how to take a medication on a schedule. Other factors for patients are how to search for health information, how to act on public health alerts, for example, how to know to boil water when there's a boil water alert, how to eat healthy foods. We talk to people often in healthcare about being healthy or losing weight, but we don't always tell people how to do that and how to make it apply to their life. Another example is how to follow the exact instruction given by a provider. Other examples of health literacy in action from a provider perspective, how to actually give clear instructions about taking a medicine, how to keep a busy schedule, how to be open to different health beliefs, so thinking about alternative medicine and cultural beliefs when those come up from patients. Another factor is how to work with diverse patients. And then some system factors. We talk about designing information and signs to help patients navigate, but we also have to think about how to explain insurance rules so patients know how to use it, what's covered by their plan or not, how to create patient-friendly spaces to lessen stress, how to help use intake forms or other health materials that are easy to read and fill out, how to help patients understand the office policies and procedures and rules, what happens when they don't show up for their appointment or they show up 30 minutes late or they need to leave early. Other system factors is how to think about referring patients to resources that they need, which is common in this field. And really there's a skills mismatch between what we need people to do, what the health system requires, and what patients can actually do. We know that education materials are written well beyond most people's ability to understand. Most people write health education materials at levels that are 10th grade or higher. Most people are comfortable reading at 6th grade or lower. And when you feel poor, when your health is bad or you're in an uncertain situation, you want to read at a really comfortable low level so that you don't have to think too much about the content in your reading skills, and you can process and understand what you need to learn and what's new over being scared. Healthcare providers often also use jargon that's unfamiliar to most people. So in medical school or nursing school or social work school, whatever field you're in, you learn the specific language of that profession to talk to your peers. You learn how to write that in the medical record so that you can communicate with other peers about what needs to happen with patients. That's not exactly the same thing that patients need to understand or their family members. It's a different language, and we need to learn how to make that translation so people can understand the skills that they need to follow and how to actually do what it is we need them to do. And health literacy is a major problem in the United States. So we know that 93 million American adults lack the health literacy skills they need to understand and use health information and navigate the healthcare environment or system. This statistic is attributed to the fact that 1 in 5 adults have health literacy skills considered to be below basic. For example, that means that they can't do things like take the appointment that you give them and write it down in a calendar in such a way that they can get to the appointment and actually follow the instruction that they need to get to the place that they're supposed to be on time. They also can't manage chronic conditions or determine what vaccine a child needs at what age, how to calculate dosage and timing throughout the course of a day. So if you think of all the rules and information that people need to process in transplant, you can see how this is a major issue. And low health literacy is linked to poor health. To start with, people with low health literacy are more likely to self-report that they have overall poor health. They also have 60% more emergency room visits than those people with adequate health literacy. So this is partially due to lack of access to primary care services and preventive services to stay healthy, the knowledge of where to go and when, and unclear instructions of what to do. So not understanding from their providers in the systems when they actually need to show up and what's a problem and what's not. Low health literacy also leads to more hospitalizations. People with low health literacy are 46% more likely to be readmitted within 30 days of discharge than those with adequate health literacy. This in part is due to unclear discharge paperwork and instructions and a person's being unclear on the needed follow-up. People with low health literacy also tend to be hospitalized longer than people with high health literacy for the same conditions. This leads to higher healthcare costs. And all of these factors worsen over time until people are severely chronically ill and eventually die from a condition that could have been maintained through outpatient and self-care. In fact, older adults with low health literacy have 50% higher mortality rates than those with higher health literacy. We know that there are many populations that are more vulnerable to low or limited health literacy. So when we think about the elderly, or people with lower income levels, people with lower education levels, or people with limited English proficiency, or for whom English is a second language. So in transplant and dialysis, you can think maybe that many of the patients and family members you're helping to make decisions fall into the categories we just talked about. And then you layer the necessary requirements to manage their kidney disease and make decisions about treatment options and follow the complex care plans, you realize that this is a significant issue for folks. So one of the strategies that we talk about in every single talk we get is this idea of universal precautions for health communication. We know that some people are at greater risk for low health literacy, but we also know that everybody is at risk for misunderstanding health information sometimes. Often when we're hearing things for the first time or we're scared or uncomfortable, it's harder to process information. So because we know everyone is at risk for misunderstanding, we recommend a universal precaution approach when thinking about health literacy interventions. So if you think about this idea in clinical care that you wash your hands with every patient, we use gowns, gloves, and masks, we handle needles safely, we inject patients correctly, all of these things happen with a universal precaution framework. The same thing needs to be applied to health communications. We know that we can't look at someone and tell whether or not they're at risk for misunderstanding, So we want to make sure that we use clear communication with every patient every time to reduce the chance of misunderstanding. And studies have shown that even people who can read at higher levels or have more knowledge of health still prefer very simple health communication. So there are some patient barriers that we should talk about, though. Patients have many factors that are barriers to the healthcare, including their traditional literacy skills. So people who have trouble reading, writing, and comprehension, those factors influence their ability to read and act on information you give them, like filling out forms, reading the health materials, or the health education. Also, we know that people's communication skills influence their ability to communicate or ask you questions. So people who speak other languages or feel like their grammar or their ability to communicate clearly is not as professional, maybe because they didn't have as much school as the professionals that they're dealing with. People who are uncomfortable with that may be uncomfortable asking questions because they think they'll be judged, perhaps. Patients also have concern about their knowledge of health topics like their medical history, and it impacts their ability to make decisions. If you have limited or inaccurate knowledge about your body or the cause of disease, you may not understand the relationship between factors like your lifestyle and health outcomes, or you might not even know when to seek care or to ask a question. We often ask people with a hand on the door, do you have any questions? That's really hard for a person who doesn't understand maybe the scope of the questions that are even relevant. So we have to think more carefully about how to help people feel comfortable sharing information and help them frame the kinds of questions that might be useful. And I'll give you some examples as we go along. Emotions and attitudes can also serve as a barrier to health communications. So we know that healthcare situations are uncertain and stressful for people, and we won't always know what your patients experienced just before they arrived at your center. We don't know what else they have going on in their mind. We don't know much about their social support systems until they share that with us. We don't know how much health information they have, and we don't know how stressful what we're telling them is for them. So what we do know is that even if a person has a high level of health literacy, they may not hear and understand everything you're explaining when you're giving them the health information. They may not hear it the first time, and they may need to be able to write it down, record it, listen to it again so they can come back and really understand. Attitudes toward health and healthcare also impact a person's understanding. For example, some people have a mistrust of the healthcare system because of their past events, and this can affect everything that you say or their perception going into care in the first place. And the final statistics I think that's really important about this is there's research that show that patients forget about 80% of the information you give them as soon as they leave a doctor's office. And of the 20% that they remember, about half of that they remember incorrectly. So people walk out with very limited information based on all the information that you've shared with them. The final thing is we know that cost impacts health literacy. It's a major barrier to seeking care, and it affects where people go for care, their ability to follow through with instructions like getting their medicines, and poverty in and of itself is stressful and impacts health. These patient barriers often compound upon each other and make it much harder for people to use the system. Let's talk a little bit more about provider barriers as we go along. So we mentioned medical jargon before, so we know that healthcare is full of technical jargon, and patients don't understand these words, which means that the jargon is a barrier in communication between you and your patient. And even the words that we think of as common in the medical profession may not be familiar to patients. I'll show you some examples of these earlier. We also know that sometimes the information we provide is unclear to patients, and we communicate the same information over and over, but it's not always received in the way that we intended. One example that we have is there's an audio tape study where 336 medical appointments with 34 doctors were taped. What they know is that doctors in those taped visits spent about a minute giving information, and 88% of that information was worded in technical language. But when they asked the doctors how much time they spent, they felt like they spent about 9 minutes. So our perception of what we've said to people and how much time we've spent is very different than the reality of what time is spent. And the way that we communicate is maybe based on provider comfort versus patient understanding. And then the final barrier from a provider perspective I want to talk just a minute about is this idea of working with diverse patients. There are organizations that have entire trainings on cultural competency, so I'm not going to do that here. But just this idea that we need to think about how impossible it is for us to be an expert on every culture, and these differences in cultures and how people perceive that really can be a barrier to building a strong provider-patient relationship, and it requires an open mind to think about that. So any preconceived notions or negative and disrespectful attitudes can be a barrier, and patients understand those. Those things poison the relationship and create distrust and dissatisfaction. So thinking about what's in your head and how that translates to people from both your words and your body language is a really important consideration for providers. And we talked just a little bit before about system barriers. So again, this idea of the system as a complex healthcare system that is not only just the systems that people enter for their own care, but the health insurance system that's layered on top of that and how people pay for services. There's the built environment. We have to think about how to get to and from facilities and find our way around it. We need to be able to have access to healthy foods when we're there. We need to have quality neighborhoods and housing so we can store medicines. And often we talk to people about exercise and physical activity to help them be well. But if they live in built environments where that's impossible, that's a pretty complex recommendation. We also talk about the culture of medicine as a system barrier. Again, this idea of the culture of medicine here in the U.S. is an individualistic system, which means we place the emphasis on people. But when we think about what that means with respect to something like the HIPAA laws, we have to give permission to have our information talked about with our family members, which is important for many reasons. But this makes things very difficult for patients with a group or family orientation who want close other people involved in their care, and they want to think about how to navigate that care. So if we try to figure out how to connect all these pieces and meet the requirements that we have at the same time that we meet system-level requirements for patients and their families, it's a really difficult situation. So I'm going to shift gears and talk a little bit about the strategies that we can use, because the problem in and of itself is big and complicated, and I think you get the idea. So one of the first strategies that we always talk about in health literacy is this idea of communicating in plain language. And the simplest explanation of this is communication your audience can understand the very first time they read or hear it. Another way I like to talk about this is living room language. So if you think about the conversation that you have with your family members at your own house, we don't use medical jargon and complicated words often. We talk to our young children, our grandparents, our partners in ways that are sort of relaxed and clear, and we make sure that we check for their understanding before we continue to go on to the next topic. That's very much plain language. Here's some examples of jargon. We talk to people in plain language about watching out for jargon. These are words that require special knowledge to be understood. One of the things that we say to folks is if you're wondering whether a word is jargon, it probably is, or at least it's problematic. So some of the things you can do to avoid jargon is replace jargon words with simple or more common words. So again, living room language. Or you can give a simple explanation for words that patients need to know, and you can teach them. So in your case of transplant, for example, some of the words they're going to hear over and over again, and they need to learn those. So it may be important to tell them the word and then explain the definition for it and use it again and help them start to use it in their own vocabulary so they learn the word and it's not jargon anymore because they've heard it over and over again. One of the important things about this slide, though, I want to draw your attention to is many of the words on the slide that are examples of jargon aren't actually very hard words. They're not long. They're not multi-syllable words. They're words like manage or risk, chronic. These are words that you would maybe not think of as being complicated for people. But what we've found when we test these words with people in communities, they don't know what these mean. They're familiar with hearing the words, so when you ask them if they understand them, their first response is, yeah, I know what that is. They'll shake their head. They'll cue in like they understand. But when you ask them to explain it or describe it or tell you what it means or what that means for what they're going to do, they can't define those words. So these are the kinds of words that we ask people to think really clearly about using and either explain or replace with a more simple word. Another strategy for working with folks with low health literacy, or really anyone in a universal precaution approach, is think about the three most important points of any clinical communication. And you want to think about the need-to-know information, not the nice-to-know. So how do you go about that? And the first thing you want to do is think about your patients. And if you could only tell them one thing about your topic, what would you tell them? What do you think they most need to know? And that's the most important thing to talk about. And you work your way through those three most important points. and you start with the most specific and work your way down to the least important background information. And again, if people start to ask more questions and ask for information, you can certainly provide more. But for people early on in learning, you want to start with the most simplistic need to know. So if you have a patient that's considering transplant, for example, it might be most important to tell them that transplant is a treatment, not a cure, and they're still going to need to take medicines according to a schedule. And it may be less important to give them facts like kidney disease prevalence in the United States. That's an interesting piece of information, and it may be useful background, but it's not necessary for their treatment information generally. So one of the reasons that it's really important to focus on these 3 important points, though, is that we know that people can only remember 3 or 4 things at a time. So we like to think about the information in terms of a pyramid like you see here. So what appears first is what's most important. This is what they need to learn and what you need them to do. And then the least important information comes last. So I'm going to shift to another strategy. We're going to talk about teach-back for a moment, and I know that many folks on the line are nurses, and in nursing school it's often common to use teach-back. So this may be repetitive for people, but I think it's really important to make sure that I highlight this as a best evidence strategy in health literacy. So one of the best ways to describe it, just so we're all on the same page, is a method to check that you explain things in a way your patient understood. Sometimes people call it the show me method and closing the loop. The important piece of this, though, is that communication is two-way. It's not just us lecturing to people. It's making sure that they receive the message as we intended for them to do. So the key strategies in teach-back. We want to make sure that the responsibility for patient learning is on the provider. It's our responsibility to make sure they understand. So teach-back really is a test of how well I, as the provider, explain something, not on how well the patient understood. This is not a test on them. It's a test on me. We need to make sure that we do this in such a way that it's a shame-free environment. So if we think about questions like, do you understand, or do you have questions, patients may be embarrassed to admit that they don't understand. To create a shame-free environment, we would ask the question in a different way. We would say something like, we've had a good amount of time together. We've talked about some really complicated tasks. I want to make sure that I've explained this really clearly and that we're walking out on the same page. So can you tell me what you're going to go home and tell your partner today? And let them walk back through what they heard. We're going to focus on the key messages, again, what's most important for them, and prioritize that need to know information. And it's really patient-centered, so it's a way to engage them in a conversation, and it allows us to focus on the information that they have the most trouble understanding. So when they have a problem or they teach back something incorrectly, the goal is not to go back through all of the information again. It's to really focus on those pieces that they need to hear again and we need to work through. So teach-back is often presented as a loop where you explain the concept, you ask the person to explain it back to you, you review the points they missed, and then you ask them to explain it again. And you keep working your way through as a cycle until the patient understands and you feel confident that they can go away without any difficulty explaining it to someone else in their family or their life. So the greater health literacy framework really is helpful when we think about specific health concerns like kidney failure here. And one of the widespread barriers is shared by patients, providers, and systems is a lack of quality education. And this barrier is especially relevant with transplant. So that's where we're going to shift right now. We're going to talk a little bit about education here. So one of the things that we all know is that the AST recognizes lack of education as a barrier to patient engagement and treatment. In 2015, the American Society of Transplantation and the American Society of Transplant Surgeons recommended the creation of educational tools that are validated and easy to use, yet engaging in order to increase rates of living donor kidney transplant. And when we talk about validated tools that are easy to use and engaging, that really is sort of code for health literacy. We want tools that people can use in the ways that they need to use them to learn what they need to do and make decisions. So they suggest that providers engage patients with education tools over time, and they revisit them and build upon the patient's knowledge. So they build a scaffold of sorts so that patients start to learn and process and make their own decisions. They want to share the tools and the education among all parties involved, including living donors, family members, patients. And this is part of the process that people need in order to continue helping people to be well. So we know that there's a problem, though, that providers have limited time to provide education. And so we have to think about how to provide education in such a way that patients can get that. So one of the solutions that we propose is using health literacy best evidence strategies from education and psychology to think about when people get information and how. So our colleagues at UCLA and others have thought about the application of the trans-theoretical model of behavior change to transplant education. They've applied this strategy, but it's also been applied to many other health behaviors like stopping smoking. The importance of this is it uses readiness stages based on individuals' motivation to change their behavior over time. And this is really important, reflected in behaviors that are connected to racial health disparities, including transplant. So if we think about the 5 stages, the first of this is this idea of pre-contemplation. And when people are in pre-contemplation, they're sitting thinking that they're not really going to change their behavior. This is not important. I'm not going to do anything different. This is who I am. This is what it is. And often people move to the second stage, contemplation. If you're in the contemplation stage of change, it's more thinking like, I may do this in the next 6 months. I'm thinking about what it might be like to change behavior on this idea. Next stage of change is preparation. This is when people have sort of started to make a decision. I will do this. I'm planning how. I'm putting my strategy together. The 4th stage of change is really the action stage. This is when you start to implement the activity. You're currently doing it. You're taking steps in action. And then there's the 5th stage of maintenance. So this occurs when people have taken action. They've been doing it for over 6 months. They've practiced the behavior. And I have young kids. They talk about locking behaviors in. So when you practice the behavior over and over and maintain it, it's sort of locked in and you get really good at it. And you're less likely to sort of slip back. So to really focus on how to apply transplant education to the stages of change, we have to think about what our questions are. One of the ways we can think about identifying people's readiness to change in their stage is thinking about what questions we ask. So instead of asking outright certain questions in a really direct way, you might think about things like how willing are you to learn more about transplant as a first piece of information? How willing are you to take action? And then getting down to the point of which actions are you going to take. You can think about some of these questions. Here are some other actions that might be suggested for question 3. You can think about talking to people about calling the transplant center to pursue evaluation, completing and mailing back the transplant center's new medical forms. You could perhaps invite somebody to come to the evaluation with you, come to the transplant center to complete medical tests, and follow up with transplant coordinators until the transplant evaluation is complete. These are the kinds of things that people might suggest. You can also change your living donor questions. So again, if you want to think about the questions that we might use to help people learn about their readiness stage for living donor transplantation, you might ask the questions on the screen, as well as questions like making a list of people who might be a living donor for you, asking another person to tell others about your need for a living donor transplant, asking potential donors to be tested, giving potential donors the transplant center phone number, sharing the need for a living donor with a large community like your Facebook, Twitter, or other social media. So if we think about changing these transplant questions to be really specific, action-oriented questions, this helps us encourage the patient to consider their next steps, and it gives you an opportunity to guide them in conversation, which is part of what we really want to do. So if you think about the questions that we use at each strategy. So we want to tailor education by patient stage, and this helps people motivate themselves toward activities that they can actually do. We want to shift one stage at a time. We don't want to go directly into action. We don't necessarily want to help people make huge changes immediately because most of us think in small, actionable activities. We want to inform and invite, but we don't want to pressure people. And there's really a tension here. This is like a tightrope. We want to balance our approach so that we inform people, but we don't pressure them or scare them or make them think that they have to do too much at once because we don't want to threaten people early on in the process. So I'm going to give you some examples here of the kinds of things that might be useful to people. So if you're meeting people where they are and tailor the education, if someone's in pre-contemplation, they might say something like, I won't do this. And so your job as an educator is to start the plant the seed and offer gentle support. And we want to honor where they are and think about how we can help them. So some of the questions we might ask is, what's important in your life? If you're on dialysis, how's that working for you? And how's it affecting others in your life? And help them start that conversation about what making a change, what a small action might do to change their life in some way. In pre-contemplation, it may look more something, as we move from pre-contemplation to contemplation, it may look like something like shifting doubt, right? So we want to invite them to learn and think about the pros and cons of what's happening. So questions to ask in that case may be things like, what do you think about transplant? And what do you think about living donation? So they can then start processing that information and think about considerations. In the next stage in preparation, this really begins with helping them begin the process and develop a plan, take the first step and start date. So some questions you might ask then is, what step would you like to take first? So this becomes them thinking about what they can do. And we talked about questions a minute ago of the kinds of things that you might ask at this point. But when people can't come up with questions right off the bat, you have connections to activities that maybe you can remind them from other patients. But you can also then start, thinking about what support they need and how you can support them as they make shifts throughout the process. In the action maintenance stage, they're currently doing it, so you want to support them not dropping out. You want to help them think about how they're doing with their transplant journey and their progress, and how you can support them as they move along. So the kinds of questions shift a little bit, but it helps them start to put things in prioritized order and sequence what they're going to do and how they're going to do it. So when you think about small changes that people have, sometimes people think, why don't we just, rush along the process, or what kinds of conversations that we can have. And this slide is really important as it starts to show you that really whatever stage people are in, they're willing to do some work. And you can see that other than people in pre-contemplation, at the point of contemplation all the way across, scores are really high for almost every activity. So people at any stage are willing to accept someone's offer to donate, allow other people to talk about it. They're willing to share education materials and talk to people about their interests. They're even willing to sort of broadly share their need for a living donor with a large community. What they're not willing to do, really, at the early stages in particularly, but even sort of uncomfortably at the higher stages, is ask someone directly to be tested and start that process. And so learning how to get people acting in the earlier stages toward this activity and then really support the sensitivity of the big ask is an important consideration. So we want to support small steps, keeping them going, and help them not be stressed out about asking a potential donor unless they're really ready to do so. So the words matter when we think about the readiness stages. We want to make sure that in education we think about an invitation to learn instead of you should. None of us like to be told what to do. We all like to sort of think together and learn and grow, and we like to feel good and empowered about what we're doing. We want to support patients in taking actions that are right for them, so everybody gets a choice. There's no one answer, and while we see many people making all kinds of decisions, it's important to know that the decision for each person is different based on their own life circumstance and timing. We want to replace the words like ask with learn more or find living donors to broaden and make the requirement seem manageable for folks. At the readiness stage, the words are very different, and when we think about education that shows real stories, we want to give people at every single readiness stage stories that can apply to their life. We want them to be able to see themselves and think about what could happen if they started to have these conversations. At any readiness stage, we want to be sure to educate patients on the risks and the benefits, so both the pros and cons. And we want to remember that certain patients may need additional education support. So we may be having these strategies and these discussions over and over again. We want to reevaluate options and involve the support system all the way across the system. We don't want to assume that people will be a no just because they were a year ago, because things change over time. We want to revisit the idea with patients who are on the waiting list. And we really want to be sure to include family and friends in the process and the discussion. In the readiness stage, we want to think about small change, and we want to address misconceptions. So if people resist, we take a step back, and we really move one step at a time. And then we want to think about the old myths, like I'm too old to do this. We want to think about what that means and why a person would say that and help them sort of work through a conversation versus say yes or no or you should, but help them think all the way. So here's an example of how we might talk about pros and cons with patients. So if you think about staying on dialysis, the pros, some of them are listed here on the left and on the cons on the right. The same thing for getting a deceased donor transplant or getting a living donor transplant. So with every patient, we want to walk through the pros and cons of all the treatment options to help them understand the advantages and disadvantages and decide for themselves what's best for them. So we know a little bit about when patients pursue transplants. So one of the things we know is that they pursue transplant when they see advantages of taking a behavior. They want to see many advantages. So what's important to them, they want to be able to volunteer more, they want to be able to be there for their children, all kinds of things happen. But when their advantages, their pros rise, that's when they start to really get serious about transplant. The cons you see in the red line don't really change, right? So the things that are negative then stay the same over time, but their perception of the pros increases. And then they start to talk about their fears and feel like maybe they understand more about what they want to do. And at that point, they maybe move toward taking action. So finally, I want to talk just a little bit about some of the education programs that are available. So there are many choices, many examples of health literate accessible information, and many factors influence what education you use. So one component of a health literate approach involves thinking in terms of who the audience is and how they want to get information. So written on paper, web-based, video, self-guided, led by professionals, all of these things are approaches that people can have. Education can also be focused on the patient or their caregivers. There are a lot of ways to think about it. So I'll just show you, for example, the education that we use from our friends at the Transplant Education and Education Center. Explore Transplant, Explore Living Donation. This example is a paper-based version. It shows people so it's patient-facing materials. They're written in simple, clear language to ensure clarity at a low reading level. There's a decision aid to help people think through their social support and really to structure the discussions that people have, and very practical strategies like sample wording to find donors through social media, in-person conversations, or in writing. And then there are stories of how other people found living donors. So this is one example. Another thing we do is we provide education to providers. So dialysis provider trainings better prepare providers to be able to have conversations that they need to have and structure conversations with their patients. Much of this is web-based. So again, using the example of patients sometimes want things on paper. Other patients want to be able to go online and look for information and know that it's safe and secure. Explore Transplants is one example of that. One of the things I'm really excited about today, though, is to really talk about new accessible tools. This is an example of the UNOS Kidney Transplant Learning Center. It's a key component of additions and updates to the recently relaunched Transplant Living site that UNOS houses. And it uses various health literacy principles to educate patients. So here are 3 pages. And if you haven't done it already, I would encourage you to go over and click around on the site because it's got some really great tools. And what we did is took the best evidence education from lots of partners across the country, and we put it together in one place. We've edited it to make sure it was health literacy. We took out a lot of the redundancies so that people got information in one place, in one way, but really walk through key components of information. It's publicly accessible, written at an appropriate reading level. You'll see in the first slide where we talk about what are the kidneys. There are visuals to show people where they are in the body and how it fits together. The middle panel talks about transplant, for an example. I'm showing you this because there are videos here, so patients can click on the videos and hear some of the education just directly from other people so they don't have to read. And then the third, really, I want to just acknowledge the many partners who were part of this because it really is their education that's put together in such a way to be publicly accessible. And I think it's really important to get at this idea that many patients do want to hear from us in clinics and medical settings, but they also want to then be able to go home and look up the information, think about how it fits with other pieces of information that they've heard. They want to know that it's valid and credible, and that it's really the best choice for them. And this is one way to help them do this that's free and available to the public. Another example that I want to show today is for folks who are interested in a more guided learning approach. We released my Transplant Coach. This is an accessible tool that people can get to on their computer, tablet, or phone, and it can guide patients through their healthcare options and help them make decisions about transplantation. I wish I could show you this easily through the webinar, but again, I would just encourage you to follow a link and look at this yourself a little bit, because it takes people through a series of modules. There's an animated set of characters that are diverse. They use language that's health literate and appropriate and accessible, but you can listen, you can stop and start when you want, you can go back and forth in the modules to get information. There are many of them, but people can follow along as they go. One of the other things that it does is it asks patients to enter key demographic information and health characteristics and their geographical location so they can develop a patient profile. And it generates a custom report for them that gives them specific predictions like risks and benefits connected to how long they have to wait for dialysis versus getting a deceased or living donor transplant. And then it'll print and mail these reports to them so they can take these to their doctor's appointments and other things. So you can look at these little infographics and you can sort of manipulate some of the slaughter bars here, for example, and look at what your life situation is like if you are 1 year on the waiting list versus 3 years on the waiting list. So it gives people some ability to sort of manipulate information and understand their situation. And again, they can get these graphs and take them with them wherever they go. So I just want to say special thanks again to our transplant education partner who gave us many of the tools to talk about this. And the goal really is to think about how do you think about health literate accessible information in the work that you already do all the time. So I'm interested to take any questions that you may have.
All right, great. Thank you very much, Catina, for such an insightful presentation. Before I turn it back to Linda for questions, just as a reminder for everyone, if you have questions for our presenter, please submit them using the chat feature located in the bottom left-hand corner of the screen. Now, during the Q&A time, I will have a quick poll up. I'll go ahead and put that up for you. For those of you listening in a group, if you'll please complete this poll and let us know how many people were listening, that would be fantastic and very helpful for us. So at this point, I will turn it back to Linda to moderate questions.
Thank you. I have one question for you. I do a lot of writing of patient education materials, and especially like with our consents and things like that. And I always look at the readability level using like a Flesch Kincaid type of thing, and I just can't seem to get it past 8, grade 8. And I think a lot of it is because of, like you said, some of the jargon that we use. I mean, even words I was looking, I once heard that you should not use more than 2 syllables when you're writing things like this, but it's so hard. Just some of the words that you used: qualify, complication, confidential. And these are words that we talk to our patients about, effective. And then you've got words like transplantation, tacrolimus, complication. How do we get it down even lower? Any suggestions?
Sure. So there are a couple things that we do. One of the things that we do when we're assessing a material and trying to make sure that it's as readable as it possibly can be is we go through and evaluate which words we must use. So, for example, you can't eliminate the word transplantation. That would be a problem for the work that you do. So when you do the readability level, if you've actually explained the word in plain language in such a way that people can understand, you can take the word out of the check when you do the word, take the word, the multi-syllable word out, and then run the check again to see if you reduce your reading level without the word. And if your reading level without the word and the definition is low enough, go ahead and put the word back in and assume that, it's going to be readable for people because you've actually explained it in such a way that is usable. So the fact that it's still at 8th grade level, for example, with a very hard word is okay if you have explained the word in such a way that without the word, the check works for you. If you can get it to 6th grade level with the explanation, it's okay that you have a harder word in, if that makes any sense. Does that help you?
Sure. Yeah, thank you. Thank you. Are there any other questions?
It does not look like we've received any at this point. Let's see, Linda, did you happen to have any other questions?
That was my major one. I think it's just really hard to get down to the 2-syllable words when we explain things. I'm going to be teaching with a patient in a few minutes, and I was looking at some of the things while we're talking, and I'm going, oh my. So, but like you said, if you explain what it is and kind of break it down a little bit for them, that'll be good. So I will give that a try.
Right, and you certainly, particularly with patients you see over and over again, it's really great if they can learn the vocabulary. So part of our job is to help them expand their vocabulary. So it's okay, particularly if you're in a situation where you can teach back a little bit and make sure that they understood. The bigger part is when you send them home with a structured material that doesn't have visuals, doesn't have enough white space, has very complicated words that we write like academics. That's not something that they could go home and look at with their family again and remember. So some of the work that we do is really focused on not just the words we present, but how we present them. So if you think about when do you use pictures versus not, right? We can often draw a picture. And I hear clinical folks say all the time, oh gosh, I'm not an artist. I can't possibly draw an image or draw a picture. But the fact of the matter is patients like people who aren't good at everything. So if you can sort of draw your way through something that's legible to them and helps them think with you about the explanation, then that's a really good memory aid for them, and it's a really good way for them to sort of prompt through storytelling and remember even something that's very complex. And it shows your vulnerability in a way that increases relationship and helps them like you and want to understand. And all of that is really important for the clinical experience with people. So, much more is involved than just the word on paper and the reading level in a certain way. So the other things we recommend are lots of white space. There are fonts that are more readable than others. I think you guys probably all have a little bit of experience with this. Most people do, but Arial and some of the simple fonts that are easier to look at are really important in making sure that the font's big enough that people can actually see it. There's enough space between lines. There aren't big, long paragraphs. For people who are low literacy readers, having lots of paragraphs with lots of words is harder than even big words at times. They get lost in the paragraphs and very confused and overwhelmed. So thinking about some of those things also makes a big difference. And I think, often you can tell from people's engagement with you right away what they understand or they don't. If they just take the piece of paper and don't look at it, you know that there's something about it that's off-putting. If you ask about their questions or you ask them to look at and describe something, and if they put it away or put it down or respond very quickly no, you know that there's a problem with understanding clinically. And so to think about how to further engage that conversation and help them remember, draw pictures. Again, you can make a recording. So much of the education we provide is verbal, and some people do that really, really well. So how do we let people take that with them so they can hear it again or go online and listen to somebody else? If you look at the Transplant Living site or My Transplant Coach, if that's the kind of education that aligns with what you're saying, it's really useful then to you perhaps to give people that example so that they don't have to remember everything you said today, but they can hear it again and again in other ways from other people, maybe with pictures and other things.
Yeah, and there's a lot of pictures that we can use from the internet by going to images and saying what you're trying to teach with some pictures too. So I like to use those as well. When you were showing us the pictures like with My Transplant Coach, you talked mostly about kidney and living donor. Are there any that they have on hearts or lungs or liver, anything else, or is it strictly on kidney?
So UNOS updated the whole Transplant Living site, but they did not do a full health literacy review on all the sites. So the images on most of the other parts of the site are fairly consistent, but as I understand, they intend to continue working on this. I think they've made a commitment and they understand the health literacy components and they're really excited about it, but they're sort of taking responsibility. They're trying to sort of bite off one bite at a time because it's a really big activity to sort of fix the whole thing at once. But they were really excited to get the images and the health literate content, and they were really active. So I think that they're going to continue that work to the best of their ability. It's just expensive and labor intensive, so it takes a minute.
Yes, very helpful. Thank you very much. Here's a question, Angie Corson. What pearls do you have for teaching patients when the eval is emergent? Not a stable patient on dialysis, but perhaps a very sick heart or liver patient who is worried just about staying alive from moment to moment.
So from a health literacy perspective, one of the things that we would say, again, is getting back to sort of those small pieces of conversation involving other people with them and their families and their caregivers, whatever supports they have, to help them think about very specific action steps. And going back to that pyramid slide that we talked about, so the very first most important information changes because it is sort of an imminent discussion to make a decision. So you really want to focus in on the most important fact at that moment, which is, it's a life and death situation, and the decisions maybe aren't as broad as they are at other times, right? And being very sort of clear about what decision options people have, and of those decision options, what are sort of the requirements for each. What other pieces of information do they need to know to have a decision? And then when those decisions are made, what's next? What are the outcomes? People need to know what's going to happen to them and what will happen if they don't. So again, getting back to this pro and con thing. But the most important thing we would say from a health literacy perspective is really this idea that people can't remember more than 3 or 4 things at a time, and they can't factor those things in. So being able to think very clearly about what's most important and who else is around to support the conversation so that the person doesn't have to remember it all on their own, and they can weigh it with family members and make good decisions about whatever it is that they're going to need to do.
Thank you. And right now we try to get the patients out in such a short period of time. Like I said, I'm going up to teach a patient right after our conversation here, and we want to get her home by Friday. So when you think of all the things that we have to teach by then, trying to get just 3 or 4 in a day, there's still so much more. So we do really bombard them, and we just have to keep, when they come back for clinic, talking to them about the same things over and over again. So it's hard to get
Yeah. Then I would just remind us, though, that if we're bombarding them with all that stuff for the checkbox, they're really not getting it, right? And one of my sort of health literacy pet peeves is we talk a lot about compliance and adherence in the medical field. And we talk about people who don't comply and people who don't adhere. And what I maintain is that for the most part, people who don't comply and adhere are people who didn't get it in the first place. And that's often because we're rushing to get information to them because we need to. We have to have the checkbox for discharge. But they never got it in the first place. So figuring out how to give them the absolute required information that is action-oriented and necessary, teaching that back so we're sure they've got it, and then following up in all those places that you said, so clinic, follow-up appointments, follow-up calls, what other mechanisms you have to make sure that you use all the resources. But it doesn't have to be all at once, certainly.
Agreed.
Thank you.
All right. Well, thank you very much, ladies. We would like to extend our thanks one more time to Dr. Catina O'Leary and to Linda Oler for their time and for a fantastic presentation today. And to all of our participants, we thank you so much for your time, and we wish you a wonderful rest of your week. Thank you very much, and take care.